welcome to everyone. Today we will be having a rural community focused webinar in Growing Stronger Together, Building Rural Recovery Ecosystems Through Trust and Community Connections. So first, we just want to give a little bit of an acknowledgement. We are the Southeast PTTC. We're funded through SAMHSA, and the opinions that you're going to hear today may not necessarily reflect the official views of SAMHSA or the federal government. So the PTTC is a national network of regional centers that equips the prevention workforce with all the tools and trainings that you all need to perform your jobs well. We're here to serve you and try to provide whatever training tools, etc., that you need in your important work that you're doing. So this is the map that shows the locations of all the different centers. You can see we are there in the bottom right hand. We are the Southeast PTTC, housed at Wake Forest School of Medicine in Winston-Salem, North Carolina. So just a little bit of housekeeping for you guys, and we'll repeat this as well towards the end, but after the webinar and at the very end of the webinar today, we'll give you a slide that has a QR code. We'll give you the link in the chat, and that will take you to an evaluation form. And after you fill out the evaluation is to help us help you. It lets us know what you thought of today's webinar and also gives you the opportunity to give your opinions for like future ideas and stuff to build on. And once you complete that form, you will get the certificate of attendance for being here today. It will open in a new tab or a new window, so just be aware of that. And then you can download it from there and add your name to it. We'll also have the webinar recording available, the slides from today, and any other relevant information. You'll be getting an email from me, Angelica Kristen, in the next couple of days, and then a second one over the next week, just so you have everything and have access to everything. So today's presenters are Michael Meit. He's the director of the East Tennessee State University Center for Rural Health and Research, and Shelly Steiner, who is a prevention implementation specialist with the Kentucky Department for Behavioral Health, Developmental, and Intellectual Disabilities. And with that, I will turn it over to Carlton Hall, who will help us introduce the speakers and the topic today. So thank you. Carlton, are you there?
There we go.
I think Carlton. I think he might have dropped off.
It looks like we lost Carlton.
Yeah, I think he's fallen off. So I'm sure he'll be back in just a minute. But if you would like to share the first slides, and then we can just go ahead and get started and welcome him back.
Good. And
for some reason, I'm not getting my video. I can't turn my camera on.
That's all right. You don't have to, and it should be fine. Sorry. Okay. I think we are good. Michael, if you'd like to start, feel free.
Yeah, and my slides are showing okay?
Yes, you're good.
All right, perfect. So yeah, I'll be happy to jump things off. So I'm Michael Meit. I'm at the East Tennessee State University Center for Rural Health and Research. And I just want to kick things off and give a little bit of context for what we're talking about today. And really to do that, I think we need to start with where we are in terms of the substance use issue crisis that we face in the United States. We have approximately 80,000 to 112,000 annual overdose deaths since 2020. That has actually trended up until the last couple of years. So I'm going to talk a little bit more about that. There are now 10 times more overdose deaths than there were back in 1999. And most of that is being driven by synthetic opioids, what people know as fentanyl. That drives the majority of those deaths today. Although that's shifting a little bit, and that's just what happens in the substance use disorder world is anytime you start to make progress with a substance, there usually is a new one around the corner. And that's also something I want to talk about. And in this day and age, a lot of that is what we now refer to as polysubstance use. So most drugs that people are using are not just a single drug. It is a mixture of a lot of different things. So even as we see things like stimulants on the rise, typically what is causing the fatal overdose is still fentanyl, which is now being laced into those stimulants. So the polysubstance use issue, I think, just is making this more complex. This is just what this has looked like over time. So this is a slide from the Centers for Disease Control and Prevention, and they talk about 3 waves of the opioid crisis. And I think this is really important context because we always talk about opioids as though they are one thing, and they're really not. So this really began as a prescription drug use crisis and remained that way really for the first decade. And then as states started to think about how do we clamp down on access to these prescription drugs, what they didn't think about is how do we address the underlying addiction. So what they ultimately ended up doing, I think often with good intentions, is they reduced access to prescription drugs, thinking that would solve the problem. But when people were already addicted, they moved on to other substances, and that led to this second wave, which was really this increase in heroin deaths. So people couldn't get the prescription drugs and they moved on to illicit drugs. This third wave really came a few years later when a lot of the people who were making these substances, who were dealing these substances, realized they could make a lot more money if they added synthetic opioids like fentanyl, like carfentanil to the mix, because it can be spread a lot further. They're a lot more potent. Unfortunately, the potency also makes them a lot more deadly, and you see each new wave leading to this rapid increase in overdose deaths. So this is what we're seeing today. So that graphic on the left is exactly what I just showed you. The graphic on the right is really the new information, which is the rise in stimulants. I referred to that, but it's not just that. It's really the polysubstance use. So it's still that underlying fentanyl that is driving a lot of the overdose mortality. And then just a couple more slides. I always like to show this because this helps ground things for me. When we talk about who is actually dying, this is data looking year over year. What I want you to see here is it's the 25-year to 54-year age range. And why that is important is that these are people in the prime working years. So this has economic impacts on our communities. But I think even more importantly, these are people in their prime childbearing and child rearing years. So the impacts on that next generation, I think, is really tragic and something we need to be concerned about. We want to break this cycle of intergenerational substance use. And I think this really kind of highlights that. Last couple of things I just want to say about where we are. One thing that I think people probably intuitively know or have seen is that substance use overdose mortality rose dramatically during the pandemic. Just before the pandemic, we were all excited because we saw our first drop in several years. You can see that little blip down. But then the pandemic led to isolation. It led to lack of continuity for treatment, led to a lot of depression, things that really helped spike overdose mortality. People started using more substances, and we see that rapid rise. I provide this context because this is what's happening now. And this is good news, but I say it's good news with a cautionary note. So CDC has been reporting and really actively touting this decline in overdose deaths. I worry a little bit that we are premature in celebrating this. This is real lives saved. It is absolutely good news. But when things get really high, there's sometimes a natural drop off. I'm going to show you that in a couple slides. But I worry a little bit that this is being touted in a way where we're potentially spiking the football prematurely. And this kind of highlights it. This is an article from the LA Times, and they note this decline, but you'll see what I highlighted in red here. The rates remain above pre-pandemic levels. And then this is really what this looks like. So you see that huge spike at the beginning of the pandemic. My concern is that we have now done what is often referred to in research as a return to baseline. We've returned to pre-pandemic levels. So stated another way, this is, again, good news because this is real lives saved, but this decline represents the highest rate of overdose mortality that we ever had prior to the pandemic. And that's not a reason to celebrate. It's cautious optimism, perhaps. Hopefully those declines continue. You can see that they've started to level out. But I think we need to redouble our efforts and not take our eye off the ball. And I worry when people start touting these declines, that can lead to people saying, well, now we don't need the same level of emphasis, the same level of resource. So that's my cautionary note. Last cautionary note I will also add is every time historically we have made progress, some new substance is around the bend, which leads to more overdose mortality. So the people who deal in these illicit substances, they're very clever at coming up with new substances. So again, we just always need to keep our eye on that ultimate prize. So I'm going to shift gears a little bit. And what I want to talk to you about is recovery ecosystems. I hope this is language you're familiar with. If not, I'm very pleased to be introducing it to you. This is really my only slide I'm going to show which describes what a recovery ecosystem is. And I really like this slide. It's developed by the Fletcher Group. And on the left, you have the who. So who needs to be involved in a recovery ecosystem? It's criminal justice, it's treatment providers, it's counselors, community support. What do we want to happen in a recovery ecosystem? It involves case management, it involves peer support, housing, education, employment support, second chance employment, life skills development, treatment continuity. It's all of these things that help people maintain their recovery. That's what we mean when we say recovery ecosystem. And then the ultimate outcomes, which help support those individuals, are active employment, transportation, housing, and social support. That's what we want to grow in our communities, to create an environment where people can successfully maintain their recovery. So I'm going to introduce you to a tool that we developed. It's something we're very excited about. It's called the Recovery Ecosystem Index. And this was developed with our colleagues at NORC as well as the Fletcher Group. The Fletcher Group is one of the National Technical Assistance Centers focused on rural recovery. And the goals were to measure the relative strength of rural county level recovery ecosystems, to build a platform, a mapping tool where people could access that data and see it visually, and then to provide the data back to people to help support community planning, programming, and technical assistance. I'm going to walk you through some of this, and I hope it's a tool you're able to use. The big caveat I always like to add to this, it's my big disclaimer, is that this is a tool that uses national data, and national data are limited at the community level. So recovery ecosystems, to be successful, need to exist at the community level, but we don't have good community level data to describe that. So we're trying to look at what data are available nationally that tell us something about those local efforts. When I say it's limited, my emphasis on that is because what I want all of you to do is to use this as a starting point and nothing more. This is designed to start the dialogue, to start the conversation, but to send you down the path of looking for your own better community level data to help strengthen what you know about community supports in your regions. So the first thing we did, again, national data, we tried to look for national indicators. So to be an indicator, we had two big criteria. The data had to be organized at the county level, and they had to be available for every county in the country. We wanted a national tool. And there were only 100 candidate measures that even fit those criteria. But by the time we narrowed it down, we were down to 36 measures. And again, this kind of highlights the fact that there just isn't a lot out there that really helps to describe what exists at a community level. Ultimately, these are the indicators we settled upon. You can see these 16 indicators. But what we did in our phase 2 is that we then went in to see which ones were not adding predictive value, and we narrowed it down to these. So it's fairly limited, but the idea is to start that dialogue. So we have indicators focused on treatment availability. So it is SUD treatment facilities per capita, average distance to the nearest MAT provider, and mental health providers per capita. And then this idea of recovery ecosystems. What is the continuum of SUD support? For that, we included distance to the nearest syringe service program, NA and SMART meetings per capita, whether the community has a drug court presence, and whether the community has a drug-free coalition, communities coalition. And then the last one is this policy score. And what we did is we identified 10 state level policies that we think are very important for communities to help provide support for people in recovery. And these are those policy indicators. And for every state, we know which of these are present, which of these are absent. So for this indicator, every county within a state will get the same score because they're subject to those state laws. And then, not to go into any more detail on this, I do want you to know that all of this is publicly available data. You can link to the actual data sources, the source data from our tool. And you see at the bottom of every screen I put the name of the tool or the website for the tool, rei.norc.org. All of this is here with data definitions. As you go through it, if you have any questions, please feel free to reach out to us. I do want to give you a little demo of what this tool looks like. So the big thing we want people to do is use this as a data resource. So when you log into the tool, you can really see two different views. One is drug overdose mortality. The other is the relative strength of your local recovery ecosystem. This is what the national map looks like for overdose mortality. You'll note that right now it only goes through 2022. We are actually in the process now of updating this with the latest data. We just got funding to do that. But what you'll see here is that the regions of the country that are highlighted in the heat map that really pop out are Central Appalachia, where I live, the Southwest, and then the Northeast. And those have traditionally been the areas where we see the highest levels of overdose mortality, but you see there are other places around the country as well. So this is not something that is isolated to any one region or any one community. And then this is what the view looks like on the relative strength of the recovery ecosystem. If you were eagle-eyed, and I'm going to provide some zoom-in views as well, but if you're eagle-eyed, one of the things you might notice is that those regions that have the highest overdose mortality often tend to have the strongest recovery ecosystems. On the surface, that might sound counterintuitive, but actually it's probably makes sense if you think about it a little bit more, because those are the places that had a problem they needed to react to. In places where the rates remain relatively low, they haven't invested in that system to help support people. So I think the fact that these things align is a very good sign. Again, as you zoom in, this is what that looks like. I like to focus in on Central Appalachia. So when you look at that difference between Kentucky and West Virginia, I think that's notable. Same with Virginia and Tennessee. Kentucky is really the star in this story, that the state that has really invested in building those recovery supports. Some of our other states in my region need to invest more, in my opinion. And then again, this is that view showing overdose mortality, and you can see this is why we need that greater investment. So other things you can do with this tool, you can overlay those. So this is essentially an overlay of the prior two maps that I showed you. So now those pink dots, the size of those dots is the rate of overdose mortality. And you see the bigger dots in those Central Appalachian areas. One of the things I encourage people to do with this tool, and one of the things that I think is really interesting, is finding areas where there's a misalignment. So I picked on this one county, just a random county that I looked at, but it jumped out at me because in Lincoln County, West Virginia, we have a very high overdose mortality rate, but a very weak recovery ecosystem. That imbalance tells me that there's room for improvement, room for investment. So I think it's interesting to look and see where those things do not align. And then the best thing about this tool, again, in my opinion, is that you get that source data. So again, looking at Lincoln County, West Virginia, you can pull any one of these data components regarding the recovery ecosystem. And you can see how you compare to your state, how you compare to the nation. And in this example here, you can see, for example, for mental health providers, the county has much lower rates of mental health access, fewer social associations per capita. You can see some of the challenges. And then other data you can pull, again, of course, you can pull the drug overdose mortality data and then the substance or the policy data as well. So you can see for your state, which of those policies are in place and which are not. So all of the other data is available as well, and you can create unique maps within the tool on any of these data sets. This is now showing substance use treatment per capita. Again, you can see that Kentucky is the star here, where West Virginia and some of our other states lag a little bit behind. Now on the left, you can see distance to syringe service programs. On the right, you can see the availability of drug court. This is an area where West Virginia does particularly well. And there are more and more of these views. And then, as I mentioned, you can download all of this data and see what it means for your communities. So here's what we want people to do with this, is we want people to access this data for community discussions. And you can access data on the recovery ecosystem, drug overdose mortality, as well as sociodemographic and economic data. We think that's important, particularly as you use this information to support grant proposals, for example. And then these are the discussions we'd like you to have. We want people to talk about what are the gaps in our community? Where do we need more data? Very, very importantly, and this gets into my next slide, what additional data are available? So is there local data that really add to this story? How can we strengthen our recovery ecosystem? Who do we need to involve in that process? And then what other factors help to impact our recovery ecosystem? And then, as I mentioned, we hope this is a call to action to think about local data that can supplement this story. This is something we've done here in East Tennessee. So this is what our recovery ecosystem map looks like. And we have mapped 344 assets in our communities, just in our 10-county Northeast Tennessee region. And then we also hope that people use this to communicate with policymakers. One of the functions of the tool is that it allows you to create state-only maps. So again, if you're in West Virginia, you can show these maps and you can show those misalignments and where investment is needed. And then you can also show how your state compares to other states relative to those state policy scores. So if your state has fewer of those policies in place, again, we think it's a call to action to say we want to be as strong in this area as Illinois and New York and Louisiana. And that's all I'm going to show you on the Recovery Ecosystem Index. Here's where I like to end, though. I like to end with a real-world example, and this is one of my favorite stories to tell. It's work that I did, it's been a little while, but we did this in Eastern Kentucky, where, as you saw in our maps, they've invested heavily in creating and strengthening those recovery ecosystems. So I'm going to start with a map. This is not a substance use map, but it's a map that I think helps to really highlight how amazing this story is. So what you're looking at now is a map of persistent poverty counties in the United States. These are the poorest counties in the entire country. They're counties where more than 20% of their population has lived below the federal poverty line since the 1980 census and every census since. That means these are counties that have experienced more than 40 years of intergenerational poverty. If they blipped up once over that 20%, they wouldn't even be on the map. So these are counties where we know that there are challenges because there's high rates of poverty. And when we talk about things like social drivers of health, knowing that poverty is such an important driver, you might think that these counties are challenged in such a way that not much good could be happening here. But I want to zoom in again to Eastern Kentucky. Again, this is the biggest cluster of persistent poverty counties in Central Appalachia. I'm going to let you focus in on that and then look at this map. So now you see those counties are green. And I can zoom in again here. It's a little blurry, but I can zoom in again. What you're looking at here are drug overdose mortality rates across two aggregated 5-year timeframes. So we looked at data in the first cluster from 2008 to 2012 and the second cluster from 2013 to 2014 or 2017. We did that so that we could have sufficient data to not have to suppress data for counties. And what we found when comparing the first 5 years to the second 5 years is that 8 of the 10 counties in the entire United States with the highest or the greatest decline in overdose mortality are clustered in Eastern Kentucky. In this instance, the red counties, those darker counties in the kind of the reddy brown, those are the counties with the steepest increase in overdose mortality over that time period. The green counties are the places with the steepest decrease. The fact that 8 of 10 in the entire country are clustered in Eastern Kentucky is remarkable. 14 of the top 20, again, are clustered in Eastern Kentucky. That's not an accident, that's an investment. And then these are those 8 counties. And what I want you to notice here is the rate of decline. So Clay County, a rate of 52.2 deaths per 100,000 is absolutely stunning. So during this time period, the overdose mortality rate was 25.5. So that county alone saw deaths decline by more than double the US rate. That's stunning. And all of these have huge, huge declines. What I also want you to notice, though, is that the rates, even in Clay County, still remain higher than that national average of 25.5. Again, we don't want to spike the ball prematurely. It's a reason to celebrate. It's great success, but there's still work to be done. When we did this study, we met with people in these communities. We talked to them about what was happening, what was the reason for these declines. The first challenge we had in having those discussions was that people didn't realize things were going in the right direction in their communities because there's still a lot of people dying. And I think that's really the key here. I always tell people it doesn't matter whether you're 10 feet underwater or 10 inches underwater, you're still drowning. And that's how it feels in these communities. So this is what we learned when we talked to people. The themes about why overdose mortality rates were declining, increased access to treatment. Kentucky expanded their Medicaid program. And when they did that, they included a dedicated benefit with payment parity for substance use treatment. When you pay for treatment, treatment providers will provide it. They invested in recovery community initiatives, things that I'm talking about and referring to as recovery ecosystem items, things like recovery housing, second chance employment. They engaged their criminal justice system. Judges across Eastern Kentucky are now more likely to refer people to treatment than put them in jail. They also engage their police officers. One of the programs that I think is really cool and is what they refer to as the Angel Initiative, where you can walk into a police station, a state police barracks, and they will help get you to treatment. I don't know that anybody has ever done that. I don't think most people find treatment by walking into a state police barracks, but it told the police, it told the state police, you are part of the solution, and it engaged them as partners. And I think that's genius. Harm reduction. So this is needle exchange. It is still controversial, but it is a touch point to start to engage with people who are using substances. And many of those people, through the relationships, find treatment and find recovery. And Kentucky has the most harm reduction sites of any state in the United States. That's an investment. A lot of efforts to reduce stigma, a lot of community partnerships, a lot of primary prevention, education, engaging children in camps and peer mentorship. All kinds of things really led to this decline. So it's not just one thing, but it's a lot of these factors that, again, we refer to as a recovery ecosystem. The one thing I do note as well is that during the time that we did this study, there were also shifts in drug patterns. That could also contribute to declines because some substances are less deadly than others. So for example, if people shifted from opioids to stimulants and those stimulants were not laced with opioids, overdose rates could be going down even as substance use continues. That could be a contributor. We don't want to rule that out. And again, that's why we don't spike footballs prematurely. And then I bring back this slide. This is the slide I showed you on the recovery ecosystem. This terminology really did not exist when we did this study initially. But as we look back, I circled all of the boxes that really contributed to that Kentucky success story. And you'll see that for the most part, every box is checked, just about every box. And what we would say today, if we wrote this report today, is that Kentucky built a recovery ecosystem, and that's what's led to that success. And if you're interested in this study, it is available on the NORC website. This is what it looks like. And with that, I'll leave this up for just a second. So if you want to reach out to me, I'm always happy to talk about these issues. But I don't want to take any more time because I know Shelly has really good information to share as well. With that, I am going to stop sharing.
Give me just a second and I'll start sharing mine.
Perfect. While Shelly is pulling up her slides, Michael, thank you so much for that extraordinary presentation. Absolutely amazing information. And what I'm hoping is that everyone will begin to formulate kind of questions. Think about this through the filters of where you all are and what it is that you all are doing and how the tools and the resources that Michael offered can connect. And that's really what Shelly here is going to kind of get into, kind of getting us the real touch about how communities engage with the system. So Shelly, it's all yours.
Thank you. One of the things that I think really to tie this together into my part is that what we've really done in Kentucky is we've built relationships, not only at the local level, but with local legislators, with state legislators, and across our departments and cabinets throughout the state. And we're starting to really work together on different projects. I'm working on a project right now, our child fatality, near fatality review. Came up with some recommendations on reducing those child fatalities and near fatalities by giving out lock boxes. And so where I work at the Department of Behavioral Health, we're working with the Department for Community-Based Services to get lock boxes into the hands of active in-home cases. We're also talking about the continuum, so prevention, treatment, recovery. Also talking to our NTPs, so our narcotic treatment programs, about because they require them to have lock boxes to take their methadone or Suboxone home. And so we're trying to get lock boxes to them so that, we're working across that continuum. And so it's all about building those relationships. And so let's think about this. Let's think about your communities. What is something unique about your rural community that outsiders often misunderstand? And if you can put it in the chat, and I'm going to ask for some help from Carlton and Chisholm and Angelica about giving some of those. What's something unique about your rural community that outsiders often misunderstand? So the closeness within rural communities, outsiders don't often have that unless they are also, and I didn't get the last of that. It looks like a small town, but everything was within a 30 minutes driving distance. Yes.
I'm driving. Can I say it instead of put it in the chat?
Yes, absolutely.
I was just going to say too, with the closeness, it's everybody knows everybody, and so I'm a peer, and so but the company I work for is not in my county, and they're just amazed at, like, every time that somebody comes as a referral, they're like, you know, I 9 times out of 10 I know who they are, and but it's been able to use that to kind of you kind of skip some of this, you know, establishing. They've already know, you know what I'm saying? They've known me for years. They, you know, we've crossed paths or whatever, and it's kind of been a smooth transition going in. That trust is kind of already there.
Yes. Which is the basis for relationship building.
A few more, Shelly. The same people are at the table at many different meetings.
Mm-hmm.
Tight-knit connections and access to decision makers and organizations. The lack of engagement in our rural towns from our government, power rates, internet, insurance, flood in particular, are combined with job market honestly makes it more expensive than a lot of other parts of the state. Agriculture communities and farming not knowing the culture, limited resources. And they're still coming in fast and furious.
Thank you for that. I mean, that really goes into what we're going to talk about, which is, you know, understanding rural communities. So understanding rural context. There is no one size fits all rural strategy, and we know that. Different rural communities may vary by geography, economic conditions, faith traditions, tribal or indigenous identity, Appalachian values, agricultural communities, or frontier regions. And we know that effective prevention begins with understanding the values and the realities of rural communities. We know there's strong social connection. There's privacy and stigma concerns, limited access to services, like a lot of you all were saying in the chat, multi-generational relationships, higher visibility that everyone knows everyone, and greater self-reliance and skepticism of outside systems. So we know programs succeed when communities feel respected, when they feel heard, and included in decision making. So considerations in rural prevention work, trust must be earned. We have to address stigma carefully, and we have to honor that local identity. So when we talk about trust must be earned, in many rural communities, relationships come before programs, and credibility comes before messaging. So some of the lessons we've learned is you have to spend time present in the community, be seen as a part of that community, especially if you don't live there. Attend local events and festivals. Avoid parachuting in with solutions. I know a lot of times when they hear about the state coming in to try to tell them something, they kind of close their ears. So don't parachute in with solutions of what they must do. You know, those doing work may see other needs, but starting with what the community identifies as most important helps build that trust and allows you to be a partner in addressing those priorities. From there, it creates an opportunity to help the community identify and address other needs over time. So use your connections. If you're related to someone in that community or you know someone, use those connections to get you in the door. If you don't partner with trusted people or organizations in the community, it's hard to get that across. So some trusted messengers may include faith leaders, school staff, coaches, cooperative extension agents, recovery community leaders, local healthcare providers, parents, and grandparents. When we started our DFC coalition in Carter County, Kentucky, the chairperson was the president of the bank. He told us, he said, I don't have a lot of time to do this. He said, but I have those connections and I can make those connections for you all. So he was the face of our coalition, and got us in the door, but then we were the ones that got in there and did the work. So it's having those connections. Trust must be earned. If you are not from there, then you must show up. Be consistent in being seen in that community. If it is just for meetings, how are you showing up? Are you just showing up then leaving? Or do you show up early to see if you can help set up? Do you voice your opinions? Bring resources that are useful, or stay late and help clean up while having conversations to make those connections. Remember, you have to give a little to get a little. If you ask someone to be on your board or coalition, especially in a rural community, then expect them to ask you to be a part of theirs or to participate in an event they are having. Address stigma carefully. A lot of people in rural communities have a fear of judgment. So fear that they will get into trouble. They have concerns about confidentiality. They are very private and want to make sure nothing comes back on them. Generational attitudes towards mental health and substance use. Older folks think of it like a moral failing. Very private, or they don't want to admit when there is a problem. They come from the buck up and deal with it generation, or pull your bootstraps on and move on. Prevention insights to use strength-based language focused on wellness, on resilience, on family support, community health, and building protective factors rather than stigmatizing language, blame, punishment, or labeling. Rural people are private and don't like to admit problems are happening to them or their families. When you address stigma carefully, a lot of times you don't face it head on like a bull in a china shop. You have to finesse it by educating the audience. It may look like having someone from that community to do a short training on opioids and naloxone. Or it may be helping a family in crisis to find resources close to their home. Or using language that uses person-first language to reduce stigma and negative bias when discussing substance use and addiction. We also want to honor local identity. Avoid framing rural communities only through deficits, because that's a lot of times what we hear, or statistics. Instead, highlight their strengths, highlight their traditions and local leadership. Instead of this community has a substance use problem, use this community is working together to support healthy youth and families. When we're honoring local identity, some areas may take to certain ways of doing things in the wrong way due to values or relationships already in place. In some areas, they may not take to hearing about something new from someone not from that area. They may feel like you're a stranger coming in and telling them how to do something. Work with a trusted local person or organization to be the one to discuss the idea. Another way to honor local identity is to participate in harvest festivals, community celebrations, or heritage days to preserve these traditions and pass them on to younger generations. And having the youth involved. If we want to have youth stay in our areas, in those rural communities. We've got to have them be part of the solution. What actually works in rural prevention? Relationship-based collaboration. So strong partnerships are the foundation of sustainable prevention. Examples of partners are schools, health departments, law enforcement, healthcare systems, youth serving organizations, faith communities, family resource centers, local government, media. Think about the DFC 12 sectors. Collaboration allows communities to share resources, respond faster to emerging issues, and create consistent prevention messaging. Next thing is youth engagement. Youth should not only receive prevention messages, they should help shape them. When you are developing messaging or strategies, remember, for any group, nothing about us without us. So some examples of effective strategies are peer leadership programs, youth advisory councils, student-led campaigns, community service opportunities. We know that rural youth often want opportunities to contribute, to serve, to be heard, and to stay connected to their communities. If they are involved in decisions for their community or ways to make it better, they are more likely to stay when they are ready to work and raise their own families, instead of heading to bigger cities or areas with more resources. Next is focusing on protective factors across the continuum. So move beyond only discussing risk factors. Focus on the positives. And a lot of time people will jump on board with more support. Some protective factors to focus on are connected families, positive adult relationships, school engagement, cultural identity, community belonging, economic opportunity, hope for the future. Thinking about these things and how we focus in on more of those positive things and think about like other groups and organizations in the community that are doing, for instance, faith-based communities. A lot of times we'll do outreach. They'll do an ice cream social or things like that. Those are ways to make those connections. Those build positive adult relationships, they connect families, and it brings that community belonging. So all of those positive factors. Prevention across the continuum is about creating environments where healthy choices are easier choices. Flexibility and creativity matter. So rural communities often operate with limited staffing and funding. So flexibility and creativity matter. We know that successful programs adapt to local realities. An example, there's a local high school that wanted to put on a prevention-focused event for students. They had limited staff and funding, so they reached out to their community. The event was helped organized by a group of volunteers from local churches, civic groups, and community organizations. They partnered with the local agricultural co-op or extension agents to provide free or low-cost educational materials and healthy food samples. The event featured free screenings, simple fitness stations, and cooking demonstrations using locally available ingredients, all designed to be easy to set up and run with minimal equipment. Also, use existing community spaces and relationships. When planning events, know who knows who and has those connections. What type of community spaces are available for free. Libraries are a great resource. Community colleges, banks, find those free spaces available in your community. Some examples are prevention activities at county fairs or events, school-based family nights, church partnerships like Ice Cream Social, mobile outreach, virtual support in remote areas. Use activities going on already in the community and partner with them to give them resources to distribute at their events or come and be a part of the event. This is building your recovery ecosystem. Challenges and emerging trends. Common rural challenges that we hear in lots of places are workforce shortages, transportation barriers, broadband limitations, limited treatment access, burnout among community leaders, because like you all were saying earlier, the same people are going to all the different meetings and trying to make the decisions. And then economic stressors. You know, we've had lots of places, lots of different businesses that have been closing down. So those economic stressors are a big thing. Emerging concerns. So fentanyl and polysubstance use, vaping and nicotine products, social media influence, isolation and loneliness. Rural communities are often highly adaptable and resilient when given resources and local ownership to find solutions to these challenges and concerns. So some final takeaways is we know that change happens best when it is community driven, when it's relationship centered, when it's culturally responsive, when it's strength based and sustainable. That's how you build that sustainability, was with those relationships. So one of my closing reflections is prevention is not built through programs alone. It is built through people, through trust, and community connection. Here's my contact information. Please don't hesitate to reach out. I'm more than happy to have a conversation with you about the presentation itself or anything else. And I just want to thank the Southeast PTTC in Carlton for asking me to present. I'm so honored to be here today. So thank you all so very much.
Shelly, thank you for that, and wonderful, wonderful presentation. Exactly right on point. There are a number of comments that were coming through the chat that reflected that this was resonating with folks here. I know we have just a little bit of time, but I thought we might be able to engage with some questions. So I'm asking for folks, if you have questions for either Michael or Shelly, please put that in the chat, or any comments that you might want to offer. Please put that in the chat for us. But I'm just really struck by the fact that when we often come to the conversation about how we address, substance use prevention and recovery services and support in rural communities, we usually start off with conversations about kind of what we don't have in our communities, and we often come from the fact that there's kind of these known challenges such as transportation and geography, lack of resources, and the like. However, what you two very, very clearly demonstrated is that there's incredible strengths in our rural communities, right? That can be built upon relationships that are long-standing, that's intertwined with history and trust, that can be built upon. And when you're intentional about connecting those strengths to good data, like you were presenting, Michael, and good effective prevention efforts, like you were sharing with us, Shelly. That's to me what we're talking about when we talk about building an effective ecosystem for prevention and recovery, and the foundation of that is trust. And so I just want to thank you two, because you two, in terms of the trust thing, you're two of the most trusted voices that I am connected with here with respect to rural communities and how to support rural communities. And so a question to you, Michael, and then a question to you, Shelly. Michael, when you hit us with that information, that slide about 8 out of 10 of the most successful communities in reducing mortality, overdose mortality rates, are right there in Eastern Kentucky. Amazing, amazing. I think that I don't think many folks know about. You introduced a number of things as to what you consider were a part of it, but if there are a couple of things that you think are just really strong ideas as to why that, because that's not an accident. That's not an accident. And so, just could you speak to that just a little bit
Yeah,
more? I think
I
we
mean,
kind of went through that.
if I had to pick one thing, I think it was the Medicaid expansion in Kentucky and the way they did it.
Yeah.
They created treatment on demand. So,
Ah,
in talking to some of the substance use providers, treatment providers in Eastern Kentucky, they say it is a failure if somebody comes to them and they cannot get them in treatment within an hour. When I talked to my county, my city manager where I live, she told me we have a 3 or 4 month waiting list. That's the difference between life and death. That's the difference
yes.
between somebody getting into treatment. I think that's probably the single biggest thing, but it is not enough because you need something on the back end too. Getting people through treatment is job one, but once they are through treatment, they need to be in an environment that supports their recovery. So that's really that recovery ecosystem piece. And Kentucky really did an exceptional job on that side of it as well.
There's a lot there that other states can really learn from and glean from. It's amazing. Kentucky, with respect to a number of areas, have always kind of tried to be out there and to be innovative with respect to what it is that they're doing. And so that's extraordinary information. Thank you, my friend. Shelley, Michael introduced a good number of tools and resources, some new ones that are being offered to help us with respect to thinking about recovery, but also the entirety of the continuum. You spoke a lot about the need for trust, and I put in the chat. What when we're working with our communities, respect is currency. You gotta come correct. If I can say it the way I grew up with it, and not do what I refer to as the Star Trek effect. When the government beams into a community, and then they're there for the funding period, and then when the funding is out, they beam out of that community and the like. What are just some thoughts that you've had? You've been doing this so successfully over the years. Our relationship goes decades. I don't want to give our age away, but our relationship goes decades. Could you share a couple of ideas as to how do we kind of diffuse that Star Trek effect and really help folks engage more meaningfully when we come with new tools, but sometimes the communities might be resistant to new tools coming on board?
Yeah, I think it's mainly really working with that community itself, because if you don't let the community come up with the solutions, it'll never last. I mean, they have to be the ones that decide what's going to happen. They have to be the ones that decide. And one of the biggest things, one of my previous supervisors, she always told me a community's problem is only as big as what it will put up with. And
Yes,
so
indeed.
that community has to decide when enough's enough and what they want to do to make it better. And so really putting it on the community to do that and giving them the tools to do it. I think that is what we really need to do, is how can we help them to make those decisions? It's not us making the decisions.
Yeah.
That community has to be the one that does it all.
Absolutely, absolutely. Well, I just genuinely want to express my appreciation to you both for bringing your intellect, for bringing your experience, and for bringing your passion to this webinar, and for all of us to benefit from all the chatter, if you will. There was a lot that folks were really able to glean from. Michael, thank you for all the resources and tools that you offered. You believe me, I'm going to be exploring each and every one of those as soon as this is over. I appreciate it. And Angelica, I'm going to turn it back over to you if you have any additional comments and guidance and directions for us.